Alrighty, so as you can see, the title has changed a little bit, but I promise I'm going to talk about what I said I would talk about when I agreed to the presentation. I also recognize that like my current setting looks a little bit weird. I took over a room in a building that's technically not mine to take over. So if anybody just burst in here, just pretend you don't see anything, we'll be just fine. But I wanted to be responsive to some of the feedback you all shared about wanting specific strategies and interventions for working with individuals who may hold marginalized identities or minoritized identities. So this is going to be a combination of theory and some application. And so I am a chat box person. I am a let's all talk to each other person. So over the next hour, I do believe it's an hour because we got lunch hour. Over the next hour, we're going to interact. Please and thank you. Okay, hopefully it'll be all right. But again, use the chat box. Even if you don't feel comfortable speaking up, we can chat. Okay. So here's what I'm going to talk about. I'm going to be real basic. I never start any presentation without setting the theoretical framework from which and the perspective from which I'm approaching things. So I will offer some definitions. The only thing we won't have specifically are case examples. That's only because I'll weave those in to the discussion as we go. If this were a longer talk, we would have some breakout groups where we would read some case studies and talk about it. Okay, so let's be real basic, okay? When we're talking about culture, it is all of these things and then some. Whenever we talk about providing cultural humility or culturally responsive care, I think we sometimes forget that culture has way more to do with food and community and music than it does just race, ethnicity. In fact, that's not even one of the major components of culture. In fact, it's behavior, shared beliefs, shared values. And we don't have to hold membership in a culture or shared beliefs and values to recognize and honor another person's culture. And again, as social workers, I know I'm preaching to the choir, but I do it just to set the stage so that way we're all on the same page. I love this image here because again, it reminds me that culture is more than just what language do you speak? It's more than just how much melanin do you have in your skin. This is another one that I really appreciate. I just noticed that Victoria also has on red glasses today. It's like we did it on purpose. They're cute. But I have these fancy glasses where I can literally take the lens off and wear a whole bunch of different colors depending on, how I feel that day. But when I think about culture, I think about it in terms of the glasses that we wear, okay? Some of us need bifocals because vision might be on the struggle bus. Some of us are nearsighted. Some of us are farsighted. Some of us just have astigmatism. Some of us literally just wear them because they're cute. But the glasses that we wear shape how we view the world. They shape how we view our patients, how we view our clients. So whether we acknowledge them or not, the glasses that we, figuratively wear contribute to how we understand a patient's presenting concern, a family's presenting concern, any of the contributors to their behavioral health conditions or their medical conditions. But we have to be mindful that everybody wears a pair of glasses and it shapes how we view things. So if you've ever heard of wearing rose-colored lenses, that's the best way to think about viewing people, families, and systems through a cultural lens. So privilege is something that makes a lot of people feel like, I don't have privilege, and their feelings get hurt a little bit when we acknowledge that, yes, we do have privilege. So here's where I need the first set of audience participation, okay? So you can either use the raise hand feature or the chat box. Raise your hand if you are left-handed. And I am flipping through and literally, okay, I see one hand raised, two, three. Let me see. One, two, I think I got 4 hands raised. Okay. You may put your hand down. I am going to intentionally ignore you again, because I know left-handed people get ignored. And so for the purposes of this demonstration, I want to go ahead and like talk to my right-handed people for a minute because I want to highlight privilege. So if you are right-handed, I want you to also use the raise hand feature and tell me the last time you had to find a desk in a classroom that allowed you to write with your right hand. Like, did you have to look for a special desk for your hand to accommodate your right-handedness? Okay, looks like one person had to look for a special desk to accommodate their right-handedness. When was the last time you had to think about whether or not you would get the indentations of a spiral notebook on your arm because you were writing on a spiral notebook as a right-handed person? Never, right? When was the last time as a right-handed person you had to take a pair of scissors and like manipulate your hand like this so that way your thumb could be on the side that the thumb holder's on? Raise your hand if you can remember the last time you had to do that. Raise your hand if you're a right-handed person and you're like, you know what, I want some ice cream. I'm gonna get an ice cream scooper, but oh my goodness, the thumb is on this side. So I gotta flip my hand again so I can actually use the thumb's little spring thingy to get the ice cream. For those of us who are right-handed, can you use the chat box or tell me at what point prior to your conception, prior to your creation, prior to you existing, you asked to be right-handed? Can anybody tell me when you asked to be right-handed? Never. Exactly. Thank you, Destiny. Never. So in the same way that those of us who are right-handed benefit from the world because of our right-handedness, because the world was made for us, we don't have to modify or adapt any of the tools we use. We don't have to flip our wrist trying to use scissors or ice cream scoopers because the world was created with us in mind and we did not ask for it. We have privilege. You cannot give it back unless you want to cut off your right hand to spite or just be weird. Like, you can't give back your right-handed privilege. And so when we think about privilege, we have to acknowledge that there are several versions of right-handedness that all of us on this call occupy. Some of us are white. I'm not. That's right-handedness. Some of us are cisgender. I am. That's right-handedness. Some of us are heterosexual. I am. That's right-handedness. Some of us have degrees. Right-handedness. Some of us have jobs. Right-handedness. Some of us have homes. Right-handedness. And not once did anybody ask to be white. Nobody asked to be right-handed. Nobody asked to be cisgender. Nobody asked to be heterosexual, but the world was made for those categories. And we benefit from our membership in those categories. And so for those people who say, well, I just worked hard, that's cute. And there are things that you have that simply are, and you can never give them back. Because unless you can tell me when you ask whoever you believe in, whatever you believe in, that you would specifically like to have the privileged characteristics that we outline, you don't get to act concerned that you actually have them. They influence the way we provide care. They influence the glasses that we wear. They influence the way people respond to us. And so if we're going to talk about culture, we got to be real about the fact that a lot of us got right hands and we're right hand dominant. The power structure that exists in a hospital room and a therapy room and in whatever spaces you occupy with patients and clients, that's right-handedness. And so we have to be willing to acknowledge the fact that most of us are hypothetically or figuratively right-handed when it comes to interacting in clinical spaces. And there's nothing inherently wrong with that. Like, you can't give it back. It's fine to be right-handed. Like, there's nothing wrong with that, okay? I've met with so many people who literally get offended when I tell them that they're right-handed. They're like, but I didn't ask for it. I'm like, I know, that's the whole point. You didn't ask for it. So, like, accept it and keep it moving. So that's like, again, just real basic. I never want to assume we're coming from the same perspective, but when I'm talking about privilege, talking about culture is those things. And both of those things function as the glasses that we wear. It is literally the water we swim in. So unless someone points out that they see the glasses we wear, it's literally how we go through life, okay? So I'm a psychologist and I'm in a Zoom room full of fellow clinicians. So I feel fairly confident speaking to you all about the things I'm about to speak to you about. Okay. So when we think about our theoretical orientations when it comes to working with people who are culturally diverse, culturally different, there are a couple different things or ways that we can approach the situation. I just want to, again, we're going to use some chat box, okay? So there's some who hold what's called the universalist perspective. And there's this idea that literally all you need is love, okay? All you need is warmth. All you need is unconditional positive regard in order for any client or patient that you see to be successful, okay? You don't have to address any of those other underlying conditions as long as you have like the core common factors existing in your therapeutic relationship. That's not inherently bad, okay? But this is called universalist, meaning you do not need to acknowledge culture. You don't need to acknowledge privilege. You're like, guess what? I have unconditional positive regard. And because of that, my patient clients are going to be amazing and awesome. How many of you all, like, and just be real with yourself, hold some portion of this view, even if it's just a tiny piece? Like, it's okay to snitch on yourself and say, yeah, I believe that all I need is the common factors. Okay. I appreciate that we have at least one person expressing the value of common factors. Anyone else? Next, we have, Lord, I'm used to having 3 screens, y'all. I'm working with one. Next, we have particularism. And there's this idea that if we recognize, cultural differences absolutely matter. Thank you, Destiny. The particularism is this idea that cultural differences create barriers that can't be overcome, and it make it so that therapists, clients, or patients won't be able to work together successfully. And so in many ways it says, yes, race, ethnicity, culture plays significant roles on their lived experience. But it also suggests that people who come from different backgrounds can never understand one another, and you can never learn from one another. You can never, grow from one another. And so again, let's tell on ourselves, how many of us hold any version or portion of this belief in particularism, that like some things just literally make us so different that like it's just not gonna work. Okay, so it looks like it does have an impact, but I don't agree it won't work. Thank you, Robin, appreciate that. I'm kind of with you, like, yeah, like we gotta acknowledge it, but it doesn't have to be like the end all be all, okay? And then here's the other one. There's transcendism, when we don't want it to work yet. Sometimes it won't work when you don't try. This is the idea that people from different ethnic and racial backgrounds are psychologically different, but we can transcend those differences. And you can learn how to effectively treat diverse patients, although there's no good substitute for good clinical judgment. This is kind of sort of where I fall. I'm kind of, to be entirely real with some of y'all, or all of you, I'm stuck between particularism and transcendism. Because like Rhonda said here at the end, if you don't want to acknowledge the role of culture and the fact that it can influence your therapeutic interventions, then no, those barriers will never be able to be transcended. But if we acknowledge that culture plays a role, that privilege plays a role, then I think we can like work together and get over some speed bumps. What are you all's thoughts about that? Where would you fall if you were to rate yourself between the 3? So chat box is good, even if you don't feel like talking to me. The same as me. Thank you, Robin. Nice to meet you. What else?
I feel the same way. I think that you have to want to do it, and I love the definition of transcendent. Sorry, I'm not saying it correctly, but I think transcendism is like the goal. But I agree 100%. I have seen instances where either side of the door or whatever, they may not. The particularism comes through, and that's very sad. But I wish that in a perfect world, I think, it would be my perfect world, right? It would be transcendism.
So, yeah,
reality hits. So
I know it. Like I sit in the middle. Like just to be real, it's stuck in the middle. I will say I had an encounter recently. I was doing a presentation for the Knoxville Area Psychological Association. It's called CAPA. I think that's what it stands for. But we were talking about the importance of representation in healthcare, particularly in mental health care. So I was sharing that, yeah, the commonalities even across the different cultures. I was sharing at this talk that for me, representation matters, and my preference is to receive care from someone who looks like me and who may have lived experiences as me. So I would love to have therapy from a Black woman. And I shared that in the city of Knoxville, I can't do that. And somebody was like, well, why? And I was like, because all of us are on this call right now. We all know each other. Like, we literally can't see each other. And then someone used the chat box and was like, well, isn't something better than nothing? And I was like, dude, you like particularist or whatever you are, like, be quiet. What is it? You universalist, be quiet, because it's okay for me to want to receive care from someone who may have shared experiences with me. But this person completely negated my preference and stated, well, what if, isn't it just about like listening and providing support and feedback? And I was like, excuse me, sir. No, thank you. But we want to make sure that in our attempt to recognize the common elements, we don't dismiss people's need and desire to feel represented and heard. And Nia has pointed out that it depends on how or who the patient is and how the partnership develops. Biases and try to be aware of them. Absolutely, we're taught to watch out for that as social workers and to be patient-centered, but also recognizing the particular systemic barriers for individual patients. That is spot on right there. And I think that's the perspective that I try to take. Like, I'm gonna check myself, and I have to recognize that I could be one of those barriers contributing to wellness for my patients because of the privileges that I have, because of the glasses that I wear. We do have to be open to self-growth, and sometimes our own biases can absolutely get in the way. Beautiful. When I teach this to like trainees, they're always afraid to say that like they were trained to be universalists. They kind of sort of want to be transcendence or whatever that T word is, because I can't say it either, Marcella. They kind of sort of want to be there, but they recognize that they got a long way to go because what they've been taught about common elements is so ingrained in, you know, how they practice, that they have to recognize all the time when they are saying all we need is love, instead of saying, you know, I really want to be mindful of the lived experience that you have. So when we think about, you know, the multicultural orientation, this is, I think, where we get to like merge the two things, the particularism as well as the transcendism. It acknowledges that, you know what, these cultural components, so philosophies, attitudes, values, the importance that we assign to these things, and the cultural experiences that patients or clients bring into the room, it helps you co-create an experience once you're in there. And it is the lens through and by which we see and understand the world around us, and it's the world through and by which our patients or clients understand the world around them. And when we're mindful of the fact that we each wear glasses, cultural glasses, we each have biases, we co-create this experience, whether it's in a hospital room, an exam room, a therapy room, who cares? But this is how we co-create the therapeutic space. Now, this is like, I'm like, oh, that's real cute. Like, I really want to be able to do this. You know, I want to be able to acknowledge that the glasses that I wear, the water that I swim in, absolutely reflects how I'm going to understand someone's experience. And I love it when I have patients or clients who also recognize that the glasses they wear, the water they swim in, impacts how I'm going to respond to them or how they're going to respond to me. And I've gotten increasingly more comfortable being uncomfortable enough to say, you know what, let's co-create this together. I need you to call me out when I say something wrong. I need you to ask questions. I need you to question my assumptions, because this is our shared space together, and the person's not going to benefit unless, as you all stated in the chat box, I'm open enough to acknowledge like my biases and my assumptions. This multicultural orientation states that culture matters. It's inescapably in the room during every single appointment. And I bet you all are completely aware of that. You know, for me, I only speak English, right? But I provide care to people who speak a range of languages. And even if we're just talking about language differences, that's a really good representation of culture showing up in the room. I can either make it be a barrier, or I can work with strategies and resources that I have to try to overcome any potential barriers that are there. So I might use language line or in-person interpreter. When we think about the multicultural orientation, we are, again, assuming that we co-create this space. It thinks about, it's almost like the acceptance and commitment-based therapy framework, where attitudes and values are the most important things that guide the change that we're looking for. You have to acknowledge culture when you are dealing with people's most salient identities. So for me, as a Black woman, if you were to be my therapist and you never acknowledge that I'm a Black woman, we would have some problems, because that is part of my most salient identity. And so if we don't acknowledge, you know, literally the things that are right in front of our faces, we lose opportunities for progress with our patients. And people who have a high degree in multicultural orientation, we really are into like self-reflecting and just challenging and critiquing our own worldviews and perspectives. I use a lot of words sometimes because I am so in my head with making sure that I'm not using like ableist language or cishet, you know, language, or anything that like continues to privilege dominant identities. And you can hear how many words and how many pauses I have just saying that to you all, because that's literally what's happening in my head. I'm attempting to be a multicultural provider who is aware of cultural differences, even as I'm talking to you. Okay. And I'm gonna go ahead and call pretty much everybody out because I don't see anybody's faces, so I don't know who I'm talking to. So I don't know if we share any like identity markers or anything like that, but that's cool. One of the cool things about you, thank you, Mayor Shelley. You can turn it back off if you want to, though. I appreciate you, though. But yeah, so I mean, you know, we're good. So when I think about the multicultural orientation, it gives us three things is what we can look at: cultural humility, cultural comfort, and cultural opportunities. And so let's get into each of these, and we're going to push pause and use the chat box a little bit for each one. So with cultural humility, there's a willingness and an openness to reflect on yourself as a cultural person. You know, you're willing to learn more about others' cultural backgrounds and identities. Now, here's the thing that gets me about cultural humility, okay? You, me, anybody who is not a member of the group that we're trying to learn about, we do not get to demand that a member of that group teach us about their group, okay, or their culture. That's not how we strive to understand another person's cultural background and identity. We cannot demand that they teach us. We also can't assume we know everything just because we read one article. So being culturally humble is this idea that I'm gonna do the work, I'm gonna try to learn, and I'm not gonna burden you to teach me how to treat you as a human. And I gotta be humble enough to know that I don't know everything, okay? When we think about cultural comfort, these are the feelings that come up before, during, and after you have these culturally relevant conversations. So some of you all are culturally uncomfortable right now. And guess what? That's cool. I don't care, because you don't change by being comfortable, okay? It's this feeling of whether you're at ease, whether you're defensive, whether you're anxious, whether you're tense, or whether you are open, non-defensive, calm, and relaxed when you talk about awareness of the contributors, the contributing factors such as culture and language, things like that. Patients oftentimes take our lead. So if we pretend that it's the most uncomfortable thing to talk about, then it's going to be the most uncomfortable thing to talk about. If you're trying to introduce an intervention that you don't think a specific group has shown a lot of interest in, if you're like, oh my gosh, I know this is weird, but I want to teach you something, like obviously they're not going to want to learn the strategy that you're teaching. So it has to be awareness that some of these conversations will absolutely be uncomfortable, and that's okay. It's all right, because that cultural discomfort creates cultural opportunities. And these are pretty cool, y'all. These are times in treatment when culture presents itself. So it could be a language thing, it could be a value, it could be a belief, it could be a religious belief, it could be food, it could be music, it could be clothing, whatever. You can either follow and explore these cultural statements, or you can miss the chance for discussion. And so I need some chat box going on or hand raises. How many times have we missed cultural opportunities because we were culturally uncomfortable? Raise your hand if you've ever missed an opportunity to talk about the impact of culture on someone's health outcomes. Thank you. Yeah, lots of hands raised. Yeah, thank you for that. I think everybody's hand should be raised in this group because there are times when I know we're like not going there, okay, for whatever reason. And I'll give you an example of times when I intentionally miss cultural opportunities. You all can lower your hands. So the clinic I work in predominantly is in a neighborhood that is like 90% Black people. But because I'm at a fairly qualified health center, we serve individuals regardless of their ability to pay, and most of them live at or below the federal poverty line. Tennessee did not expand Medicaid, so you all probably know about that, but you get stuck, and so resources are hard to come by. So I serve a lot of people, including white men who may be poor, who also think they're experiencing discrimination. And I laugh a little bit in my head because when we think about privileged identities, white, cisgender, heterosexual in the United States is the most privileged identity marker that we have, okay? And so I will absolutely avoid the opportunity to try to teach a cisgender, heterosexual white man that he has privilege, especially if there's concern where absolutely there are some poverty factors involved. I've had several white men attempt to convince me that they're more oppressed than me, and I will absolutely ignore that cultural opportunity to talk about how that's garbage, because my piece is more important than getting into that. So I say this to say that sometimes we do absolutely need to miss those cultural opportunities, especially if you are in a position where you could be harmed by addressing it, or you're not going to benefit the client or the patient at all by raising it. You just want to make a point. Like, some cultural opportunities are completely, exactly, safety first, because what we're not going to do is get harmed in my space, right? But it's okay for us to skip some cultural opportunities when we think about like the dynamics that are at play in the room, or the people who are occupying and sharing that space. Also, we want to remember that sometimes we're the people in power. Often we're the people in power because we are the people with the degrees and who are offering the services. And we have to ask ourselves, who's being served by me taking this cultural opportunity? Is it so I can check my box and say, I told them? Or is it like you really think that this would be an opportunity for growth in their wellness? And so for those of us who raise our hand stating that we miss cultural opportunities because of cultural discomfort, same. That's all I got to say, same. But there's some, particularly if, and again, I don't see everybody, so I'm just going to call folk out. If you are white, cisgender, heterosexual on this call and you don't talk about culture because you feel uncomfortable, step your game up, because it's uncomfortable to experience the things that marginalized people experience. So I need you to be culturally uncomfortable and do it anyway. That is literally the only way we are going to get back to that cultural humility component, where we take the time to understand our biases, our fears, our values, and use them toward our patient's progress. Now, again, they're not going to teach you how to take care of them or how to be more comfortable. But if you avoid conversations regarding cultural factors because you're uncomfortable, not because it's safety, but because you're like, ooh, that makes me feel uncomfortable, step your game up. And again, I don't see any of you all, but you know I'm talking to you if I'm talking to you. Step your game up, okay? that's how we take care of our patients, because again, those who live in situations where they experience hardships because of cultural factors, they don't get the choice to not be uncomfortable. So we're co-creating spaces, so we show up with them and co-create solutions if needed. Okay. Is one of these more important than the other? So is cultural humility, cultural comfort, or cultural opportunities, is either one more important than the other? And if so, which one? No. Okay, we got a no. Why not? All are important. Okay. Somebody else tell me why. I think staying humble is the key, being aware we don't know everything and just trying our best. Mm-hmm. And also with the humility, being okay with getting checked when someone calls you in. Do y'all know the difference between being called in and being called out? Being called in is when there's somebody who shares like power with you, shares an identity marker with you, and they're like, "Ooh, friend, let me tell you, we shouldn't do that. Like that wasn't cute." Okay, being called out is like you've harmed somebody, and they tell you that you harmed them, and you're like, "What?" You know, like they tell you to check yourself. I called you all in out when I said if you're white, cisgender, heterosexual, and you get uncomfortable and avoid uncomfortable conversations, do better. That's a call in and a call out, because I don't share the ethnicity component with you, but I share the mental health component. So that's an example of doing both. You either say, hey, friend, we need to do better, or how dare you, like you need to go learn something and do better. So it really can be both. I think the cultural humility allows us to accept it when someone calls us in and when someone calls us out, because we are no better than the people we work alongside or the people that we serve. Someone in the chapter wrote, yes, a holistic approach is so important. And I think as social workers, you all know that, like you all know the impact of the social drivers of health. And culture is one of the social drivers of health. Like, yes, y'all do this so well. All right. So what are important, or how important are these different elements? You know, if we're saying they're all important, well, we know, like you all are saying, that humility creates better working alliances, and it can help us when we mess up. So when we have cultural ruptures, or if we commit a microaggression against our patients. Okay, the cultural comfort does affect the rate of treatment terminations by racial ethnic minority patients. What does that mean? If you are too uncomfortable to have an uncomfortable conversation, and too scared to have an uncomfortable conversation, and you wonder why your patients no show, it's probably not them. Probably you. Okay. And when I say you, I'm talking about myself too, because there are absolutely times, again, when I know I missed the mark. But we can't blame our patients for being quote unquote non-compliant or non-adherent when we are avoiding difficult conversations because it feels weird to us. And then missed opportunities, or opportunities, if we miss the ones that matter, we can negatively, meaning we might be able to cause harm for the people that we serve. So for example, going back to that presentation I was doing last week, where the person was like, well, doesn't it just matter if all you do is like have unconditional positive regard and have somebody listen and support you? Like, I'm not going to improve if you try to put a Band-Aid on racism or sexism or gendered racism, which is something that I experience almost every day. If you just tell me, oh my goodness, you are loved, I'm not doing any better. That is not going to protect me. In fact, I'm going to hate you a little bit and probably never come back and see you, because you're missing the opportunity to learn more about how gendered racism or other forms of oppression negatively affect my wellness. Okay. So for those of you all who said they're all equally important, totally, I agree. Like, I think they function together. That's why we have the multicultural theoretical orientation, because it highlights all three components. Okay. So does the multicultural orientation apply to racial ethnic minority therapists? Yeah, because again, Sometimes our patients are the one who cause harm to us. I have been called the N word, y'all, by a white male patient in my own office. And so do I say, hey, Mr. White Man, I would really love the opportunity to talk to you about how that's a harmful thing to say. No, like we said before, safety first. I'm not talking about racism or the N word. I did kick that person out of my office though and told him he wasn't allowed to return because I don't play that. But in that moment, I'm not going to teach you nothing about how that's not an okay thing to say. Just get out my face. I experienced a bunch of microaggressions as a racial ethnic minority therapist. Some of them are like benevolent sexism, if you will, like, you know, people always want to hold the door open for you because they may think that you're too weak to do it. But some of them are just downright annoying. My all-time favorite, and this is sarcasm, whenever I have patients who are like, you know, I got this one Black friend, and I'm like, thank you for telling me you know one Black person. Appreciate it. Or they'll say, I'm not racist. My father-in-law is Black. Cool. Thank you. Thanks. Don't do that, y'all. Like, if you like, no matter what your identity is, don't try to like be down with somebody else just because you know one person who holds that identity. Intergenerational trauma is real. Okay, so like there are times when, as a Black psychologist working with Black men, I experience like re-traumatization, like mentally, as I'm there in the room with them, and it's hard to hold space for them while making safety a priority for me. So here's an example. I live in Knoxville, Tennessee, and we have a really icky relationship with law enforcement, such that if you have a mental health crisis, the police are coming first. They're going to be the ones to transport you to the hospital, if they transport you at all, because first they're going to try to convince you that you don't need help. But we've had some patients who have been transferred by police officers, and it's caused harm. So when they talk to me about that in the therapy setting, I get anxious too. I start to get afraid because even though I haven't been transported to the ER by police, I'm still terrified of police officers. Like absolutely terrified. So when they talk about encounters being transported with police or interactions with police, I'm sitting there noticing that like my hands are bunched up, or that my muscles are tense and tight, or that I'm getting increasingly anxious because I'm terrified as well. So we have to be mindful that when we are discussing these things that may be unique to some individuals compared to others, we do have to protect ourselves as well. And then, of course, there's like the pressures to assimilate. That's just day-to-day thing. Y'all aren't bothering me. You can make whatever noise you need to. No, you're fine. Do what you got to do. But pressures to assimilate, to like only use certain, you know, interventions. Some of you express concern about wanting to use like mindfulness with people who are like, yeah, right, I'm not just going to sit there and pay attention on purpose. That's okay. It's on us to learn a different modality that matches what is the preference of the person that we're serving. We can assume that every single patient will benefit from the one thing we're most comfortable with, or the one thing that research says is the best option for that. Because when you think about it, the research that was used to develop the interventions that we're supposed to use didn't include people who are minoritized, or who live below a certain income level, or who have a lower educational level. They were norms on people who were highly motivated, 75% of whom were white, educated, with money. We cannot assume that the interventions work for everybody just because the research from the original, you know, clinical trial says that it works. And that in school, we're not taught any other interventions. We're literally taught the interventions that were developed for people who are members of the dominant group. I don't use manualized interventions like straight out the box. Like, it's impossible. That's not culturally appropriate for the people I serve, because they were not included in the sample upon which the intervention was developed. So I have to modify everything. And so if we only use things straight out the box, that's like assimilating to the white dominant culture. Yeah, looking at you, CBT, say it again for the people in the back. Make sure everybody heard that. But like, you cannot do a one-to-one conversion for people who may have experienced or who are members of marginalized and minoritized identities, people for whom elements of their culture have resulted in harm, okay? And so I hope everybody has heard the word intersectionality, but I'm gonna say it again. I absolutely love the original story outlining how intersectionality became a term. So there's a reason why we're looking at General Motors on the screen. I was literally in Detroit last week. I used to live there, missed that city, but I was in Detroit last week and I saw the GM building. And I was like, this is where all this stuff happened. But either way, back in the 50s and 60s, GM in Detroit, really amazing company. It's still one of the largest employers in the state of Michigan, particularly the city of Detroit. But if you got a job at GM, you have arrived, you were doing big things. But back in the 50s and 60s, the jobs were very gendered, okay? So if you were a man and you came in to work at GM, you were likely doing, working on the line, doing the physical things. If you were a woman, you were likely to be sitting at the front as a secretary or something like that. Now, these jobs were also racialized. If you were Black, you were doing like janitorial work, behind the scenes things. But if you were white, you were more likely to be visible if somebody were to come in, okay? So keep that in mind. Men do the labor, women say, hey, Black people hide and clean up, white people are front and center. But let's say somebody like me, a Black woman, wants to work at GM. Where can I work? Because again, as a woman, I'm supposed to be in the front, but as a Black person, I'm supposed to be out of sight, out of mind. What kind of job can I have at GM as a Black woman? And so because y'all don't know where I could work, that was the crux of the original lawsuit that led to this term called intersectionality. So there was a class action suit. So they took it to the court, and the judge was like, cool, it sounds like you all experienced discrimination, but now you got to pick one. Are you here because you were discriminated against because of your gender, or are you here because you were discriminated against because of your race, ethnicity? You can only pick one. How do you pick one when, as a Black woman, there's no place for you at GM? How do you pick one? You can't. And so that trial never proceeded because the people were not able to separate their gender from their race, or the experience of discrimination based upon their gender versus their race. It was a whole gendered racism experience, and you can't separate the two. Therein lies the definition of intersectionality. It's the lens through which we see where our identities and our powers and our sources of oppression, how they collide. You literally cannot pull them apart. There is a distinct, there's this idea that you can't simply state you're a Black plus woman plus straight, because for me, you can't take the Blackness away from me. You can't take the womanness away from me. You can't take my straightness away from me. None of those components can be extricated. It's not additive, it's multiplicative, meaning you are viewing me as a whole different version of myself when you consider all the elements that make me who I am. When you only look at one element or version of who I am, you ignore the other pieces that overlap and intersect to create the lived experience that I have. What does it have to do with patients? We do the same thing with patients. We're like, oh my goodness, like you're a woman, the end. No, but what about all these other layers of experiences that our patients, that our families, that our clients bring with us? If we don't at least acknowledge the layers that create a whole different version of that person, when you think about the way the layers intersect and combine, we're not doing it right. And that goes back to the universalist perspective that one size fits all. You cannot one size fit all, folk, if you're going to take a culturally appropriate racially equitable approach. It just ain't gonna work. And if you do it, try again. Okay, it's not cool. But it doesn't mean you got to try to think about all the different ways that people, have intersecting identities. But like, don't act like you only see one thing, because it's not possible. Okay. And we have to acknowledge that we hold membership in multiple groups at the same time. And those multiple group memberships influence how we see the world, how our clients see the world, how people view them, how they interact with it. We cannot pretend that it doesn't exist. Okay. So you've heard me talk about competence versus humility. If I see one more person tell me about being culturally competent, I might scream. Because when I think about competence, I think about someone shadowing you or you taking a test, and literally every time you get something right, you get a checkbox. Like, oh, you mastered that part. You did a great job on that part. You did a great job on that part. You did a great job on that part. And that assumes there's like a perfect score. Like you can actually achieve competence at some point. But if you become an expert in somebody else's culture, like that's just weird. Like I don't think it's even possible. That means you're no longer open to learning, because people change all the time, which is why I said reading one book ain't gonna make you competent. Okay. So when we think about competent versus humble, competence assumes that there's one culture that is the dominant one, and we learn how to provide care to everybody compared to that dominant culture. So how do we modify this intervention, which was made for the dominant culture, to work for somebody else? Because apparently, like we have to compare whether or not that group is good enough to receive this thing here. It's binary. Either you are competent or you're not, and we know that's garbage. If you're incompetent, it means you don't know enough about the quote unquote other. And so that in and of itself is rough. Like we're othering people and groups of people. It's a very top-down approach, because one group decides what's worthy of being learned about that other group. One group determines what the benchmark criteria is, so you can assess the criteria. But when we talk about cultural humility, it's iterative, it's lifelong, it's uncomfortable, it never ends. You don't get a perfect score. Like you focus on yourself, not learning about somebody else exclusively. You look at your own ways of viewing the world and how that might influence how you take care of somebody else who may not share the same, things that you have. It goes way beyond just acknowledging or thinking about our beliefs, biases, and assumptions, but it requires change. And it requires us to be aware of the historical context in which a lot of our biases, beliefs, and assumptions were created. And y'all, don't say that you attended today's training and as a result of meeting with me, you're now culturally competent. No, you're not. Okay. When we talk about cultural humility, it is literally not just the training. And FYI, most of the trainings fail. The Harvard Business Review had a study that stated when they did like these large scale cultural humility changes or trainings, people reverted back to how they were before, and they were a little bit worse, like within 90 days, because people become so hyper aware and hypersensitive and afraid to step on people's toes. And then the people who hold marginalized identities are like constantly having to tell the person with the majority identity, like, I promise you're doing okay, you're doing an awesome job, it's really cool, and using their energy to affirm that the person who sat in the training is doing a good job. Like, just don't do that. Like, make it personal, learn, be okay to get called in, get called out. Okay. Psychological safety or cultural safety, literally, we just want to feel safe. I know that sounds real cheesy, but like, you got to be aware of, yourself and the impact of your own culture in your clinical interactions if we're going to create a safe space for our clients, for our patients to grow and change. We have to hold ourselves accountable for creating that culturally safe care. We can't assume that it's our job to, rewind. We can't assume that every patient wants that from us. But as the people in power, it is our job to bring it up, okay? And to say, hey, I want to be mindful of culture. I want to be mindful of ethnicity. I want to be mindful of language. And I will do my part to make sure that I am incorporating that as much as you're okay with, okay? And we have to critique taken for granted structures like power and privilege. We can't pretend it doesn't exist. So you don't get to be uncomfortable, or you don't get to, bypass conversation because you want to be cultural. You want to be comfortable. Cultural fluidity, just another way to put it, is this idea that you seamlessly interact in the space between your own personal values, beliefs, and culture, and the values, beliefs, and cultures of someone else. You examine the impact of your own culture on how you deliver healthcare. So we have, to the best of my knowledge, like 5 minutes left. So I'm gonna just show some things, but I'll give you the PDF about things that you can do with it. So barriers to treatment can create cultural barriers as well. And so all I'll say out of this is that we have to be mindful the way we understand people. Oh, we got some time then. We got to be mindful about the way we understand people's presenting concerns. So when we think about healthy paranoia, one, people who are Black and brown are more likely to be diagnosed with psychosis than white individuals because of things like healthy paranoia. Again, I'm absolutely terrified of police officers, okay? Why? Because I'm not sure if anybody knows, but the origins of police in the United States were as the slave patrol. So during times of enslavement, when the slave owners, the kidnappers, wanted to have their quote unquote property returned, they would empower and marshalize people to go find the enslaved people who may have left to be free and return them dead or alive. The same exact shield that was used for slave patrol on the emblem is on police badges. It is the same institution. And no, I have never been enslaved. No, I've never been chased on horseback by a police officer, but my ancestors were. Okay, that's where this concept of epigenetics comes from. There's a study where they had 3 generations of dogs. And during the first generation, they Pavloved them. So they exposed the dogs to actual cherry blossoms. And every time the cherry blossom flower was exposed to them, they shocked them. Okay? And those dogs had babies. And then what they would do is they would show the cherry blossom flowers to the babies. No shock. But guess what those babies did? They jumped. They were afraid, even though they never experienced the shock, because their parents had the trauma, the expression of the gene was changed, turned off, turned on at the allele. So 3rd generation of dogs, they didn't even get the actual cherry blossom flower. They were exposed to the scent of cherry blossoms. They still jumped. They never experienced a shock, never even saw the flower. But because of this thing called epigenetics, whereby the things that the people in our past have experienced environmentally change the expression of certain genes, whether it's turned on or turned off, people who have never experienced a person chasing them down on horseback can still be terrified of the police that represent the people on horseback from ages ago. Okay, so when we think about this, we got to make sure we understand a person does not have to have experienced directly the trauma they're sharing. Their family members may have, and that does not make them paranoid. Okay, it doesn't make them weird. It means they have experienced intergenerational trauma. Okay, we also have to recognize that minoritized individuals may harbor a general distrust of white providers, and I'll say this, and you'll probably get tired of hearing me talk, but whatever. When it came to the COVID vaccination, people are like, why don't Black people and brown people want to be vaccinated? Well, it had nothing to do with vaccine hesitancy. It had to do with personal safety. Because if you want to know how we know about the effects of radiation on our bodies, ask Black men who had radiation injected into their bones without their consent. If we want to know about how often you give Depo-Provera so that way you have sterilization versus contraception, ask Puerto Rican women who were injected with Depo-Provera and then end up being sterilized. If you want to know why people may not want to have surgery, ask anybody about a Mississippi appendectomy. You may have to Google that one and look up Fannie Lou Hamer. This idea that you think you're going in to get your appendix removed and ta-da, you no longer have a uterus, that you have a scar to prove it. That's why people don't trust medical professions. We don't get to be like, you trip and you're being paranoid, like this is a delusional belief. Like, no, we need to honor and acknowledge that historically, Black and brown folk have been extremely mistreated in this country. So if they don't want an injection, if they don't want a surgery, more power to you, okay? We have to think about the environment in which we function. Think about the rules. I'm not sure, a lot of you all may work in like the hospital system. So I don't know, like if you're seeing patients inpatient or separately. When I used to work at a children's hospital, I did both. I did rounds with the medical providers, and I would go see families like individually for follow-up. And when people got discharged, they would come back and see me for a few appointments if they needed to. But there was a late arrival policy. And there's a late arrival policy where I work now. And if the families arrive 15 minutes late, they were supposed to reschedule. That is not culturally informed or culturally responsive practice, because I don't know about your patients, but some of my patients have to take an hour-long bus ride to get to the clinic. And that assumes the bus is going to come on time. Our buses run whenever they feel like it. They don't know what time is. They don't know what a clock is. So if a patient arrives like 30 minutes late, but they arrive, I will absolutely still see you, because I don't know what it took for you to get to me, how long you waited outside, and this past couple of days it's been raining. So I don't know how wet you had to get before you got on the bus, but I will absolutely see you. But a structural barrier that is not culturally informed is having a 15-minute cutoff for no-shows or for arrivals, and then saying you're not going to see the person. Like, how dare we not see the person? Now they got to do it all over again on a whole nother date, okay? And then there are provider barriers. Again, we've talked about this before. I'll say it again. Alyssa told us, looking at you, CBT, this idea that we literally will only use one modality because it's the one we are most comfortable with. That's not culturally responsive care, assuming that everybody will benefit from the one modality that you know best. We got to do better. We have to learn more. We have to get uncomfortable expanding our repertoire of care and options. When we think about microaggressions, whether we are the recipient of them, if you're a minoritized therapist, or whether you may inadvertently, commit a microaggression, we have to know that there's an impact associated with that, okay? So we might find that, like, in the immediate phase, there's psychological distress. I don't know if anyone's experienced a microaggression, but for me, it makes me feel real stupid, because I'm like, did that happen? Am I tripping? Like, maybe I'm overthinking things. And I'm like seeking validation from others to make sure that, like, what I experience is really what I experience and that I'm not losing it. Imagine what that might be like for someone in your therapy setting, whatever that might look like, and we say something unintentionally and they're like, what? Am I weird? Like, really? But it causes psychological distress. It may cause us or patients to feel like they have to comply with whatever we recommend. So, or it could, we could lose our street cred, if you will, the loss of integrity. Or patients or clients might feel the need to code switch with us because they think we'll only experience them or understand them or accept them if they present one way versus another, okay? It can lead to altered therapeutic interactions. So in one research study, 53% of Black patients stated that they received a dismissive, negative statement and culturally inappropriate interventions at least once in the course of the therapy they were receiving. For me, that's completely unacceptable. Completely unacceptable, okay? And I bet a lot of it is done by people who are completely unaware of their impact on people because they may have a one-size-fits-all approach. Well, I'm really, really good at CBT, so I'm gonna do CBT with everybody. Nope, can't do that. Okay. Microaggressions also can be caused, or the negative effect of microaggressions can be caused by that cultural discomfort. So people get defensive, or they're afraid they're going to say the wrong thing, so they don't say anything at all, and therefore they miss opportunities to address real concerns that the patient's clients might present with. And in general, when microaggressions are not addressed immediately, or if we don't respond the right way, if we get defensive and say, that's not what I meant, which in and of itself is a microaggression, it leads to a weaker clinical relationship. Okay. So one of the things that I've learned best about anything when we're talking about culture, when we're talking about race, ethnicity, the whole 9 yards, is the difference between intent and impact. Because Lord knows we will intent ourselves or try to intent ourselves out of everything. Oh, I didn't mean to do it. That's not what I meant. I can't believe they thought I meant that. Chill, okay? Because the scenario I give is like, what if we walking down the street together, okay? And for some reason, I got on like steel toe boots because that's just what I want to wear that day. It's my business. And I step on your pinky toe because you got on sandals today. Now we're walking side by side. I did not intend to cause your pinky toe hurt, but does that mean your pinky toe doesn't hurt? No. Just because I didn't mean to do it doesn't mean I did not cause you harm. And so when we call each other in and call each other out, our first response cannot be, that's not what I meant. Intent versus impact. Even if you didn't mean to cause harm, we need to acknowledge the harm that's caused and work to make it better. But do not make our clients come up with a solution for how we need to make it better. Okay? Like you can't say, oh my goodness, I'm so sorry I stepped on your toe. I really didn't mean to. Like, what can I do? I really want to make it better. Why don't we want to do that? Because now you have made it about yourself, and you've made your client patient have to come up with a way to make you feel better and a solution for how you repair the harm that you caused them. So if somebody says that was hurtful, that was harmful, we cannot say, I didn't mean that. That's not what I meant. Don't do that. Just like, my bad. I'm sorry. I'll try to make up for it, or I'll do better. Like, that's how we acknowledge intent versus impact. And when we get with microaggressions, oftentimes people lean on their intent. And if I had my way, most of the time I would stab intent in the throat, because we try to intent our way out of everything without acknowledging harm that's caused. Okay. And then it is possible to repair microaggressions the same way we repair other therapeutic ruptures and snags. Okay. So Daryl Wing Stu said that there's a way to respond to microaggressions, and I'm gonna go ahead and give you my own caveat. I think most of these solutions are best enacted by people who hold positions of power. Even those of us who hold minoritized identities or multiple minoritized identities, we can also commit microaggressions. But I think when we are responding to them, I think Dr. Stu, he didn't say it explicitly, but like, these are interventions for people with privilege. So if you will hold a position of privilege on this call, the slides that come next will likely be for you. Okay, so his question was this: to speak or not to speak? That is the question. So when someone speaks up and says, that was really hurtful, we oftentimes see things like that. I'm not racist. I don't see color. We're all the same under the skin. Oh, I didn't mean it like that. I can't believe you would think I would say or do something so mean. First of all, you better see my color, because I'm not clear. Like, I need you to see me, okay? Just because we're all the same under the skin doesn't mean that the skin I live in has been respected in the same way that the skin you live in has been respected. Blood from my family, which is under the skin, has been shed because the skin that I live in hasn't been accepted as worthy of care and respect. And so this is how some folks tend to respond to microaggressions. But here's what we got to know. Like, we gonna mess up, okay? Own up to the fact that we cause harm. Don't be weird. What do I mean by don't be weird? And I've given an example. Oh my goodness, I really didn't mean to do that. I can't believe that I hurt you like that. Oh my goodness, I am so sorry. I would never do that to hurt you. Like, oh my goodness. chill. That's weird. Chill. Okay? Because not only is that like extra, it's also centering yourself. Chill with that. I've gotten really good at managing microaggressions by playing stupid. What do I mean by that? I'll give you an example. I'm on the governor's task force for health equity for rural healthcare, or whatever the case may be. And I was on the telehealth subcommittee. So talking about ways to improve the presence of remote services for people who live in rural areas where, you know, as you all know, like less internet connectivity, more difficulty because of greater length of time to get to the clinic, blah, blah, blah. So I made the recommendation that we create like the equivalent of mobile hotspots, meaning you create little stations or little booths in trusted community locations like libraries, churches, and pharmacies, where a person who needs a video appointment with the caregiver can enter this HIPAA compliant space. There's a Zoom screen waiting on them. They just connect to their appointment and ta-da, you know, we don't have to worry about increasing bandwidth in every household, just in a couple of key points in the community that people frequent a lot. And so that was my contribution to the telehealth subcommittee. But then there was this dude who was on as the representative of one of our senators. I'm not going to speak because we're being recorded. But this person decided to say, yeah, that's a great idea as long as, you know, it doesn't promote this whole woke work from home and still get paid agenda. And I was like, they kept talking and they were moving. And I was like, what does that mean? What does woke work from home mean? And the person started stumbling. They were like, well, that's not what I meant. I was just saying that's what some people would say. And I was like, no, really, I still don't understand. Can you give me an example? And he stumbled more. He was like, well, I was like, no, really? Like, I really want to know more about this woke work from home and still get paid agenda. I want to make sure I understand correctly. He had no idea what he was talking about. And so after he stumbled enough, I was like, okay, thank you so much. I said, I just want to make sure that we understand that working from home is not inherently bad and that some people are not more deserving of being able to work from home than others, if that's what you meant. And then we moved on to the next topic, but I started by playing real stupid. Like, what does that mean? And I found that to be a really successful way to address microaggressions or any cultural ruptures. Because if I'm gonna be uncomfortable, guess what? You will too. And that's what that's about. I'm gonna shift the discomfort to you. I'm not gonna solve this, you will. Okay. Power and privilege. This is just something to keep in mind. Like, I just like to use this framework when providing care, when we think about power and privilege and oppression. So if you look at the quadrants, it's just things to consider. It's a practice, a way to think about providing care depending on what your identity is and the identity that your client or patient occupies. Like, it skipped a whole lot. Okay. These are some strategies or recommendations for addressing cultural differences in clinical care. I'm not going to read them all to you, but we've talked about them today. So just recognize that we co-create space, that therapy exists within context. It does not exist in a vacuum. You can't ignore culture. You can't avoid topics that are uncomfortable. Like, because that does nobody any good, okay? I already talked about how, you know, CBT was founded on European values, and it tries to explore and modify core beliefs. But we have to consider how core beliefs and assumptions and the content of the automatic thoughts vary by cultures, okay? So some people might very well be like, it's the Lord's will. That's a cultural belief. CBT does not account for that, okay? CBT would call that an external locus of control. That we need to make sure we consider those things. We have to think about idioms of distress. We have to think about, like, how do people say that they're experiencing distress? One thing I learned when working with families that are refugees is that the word depression doesn't exist in some languages. Like the word literally doesn't exist. And so I learned quickly that when I was working with individuals who are from Burundi and they speak Kirundi, if I wanted to know about symptoms of depression, I would say, how's your heart? Does your heart hurt? Not does your chest hurt, because if your chest hurts, that means I need to get a nurse. Something's probably going on from a cardiac perspective. But how is your heart? That's how I assess for depression. But no CBT book is going to tell you to ask about somebody's heart. It's going to tell you to say, in the last 2 weeks, how often have you felt down, depressed, or hopeless? Okay. So these are ways that we can apply the clinical considerations for working with people from a culturally responsive lens. Think about the words that we use, because language is so important. When somebody doesn't make progress in the way we expect them to, like, here's some things we need to check. Does the intervention reflect things that make me most comfortable, or are they tailored for each person that I'm serving? Okay. From whose worldview is the intervention that I'm using predominantly? From whose worldview is it derived? For me, oftentimes, especially when I'm working with people who are refugees, I know that they were not included in the sample that, led to the manualization of the intervention. Do I dismiss or do I pathologize core beliefs because they don't ring true for me? Okay. Do I call them external locus of control? Do I say that somebody is being dependent? Do I say that they aren't exhibiting enough self-efficacy because it doesn't exist within my own worldview? Is it fair for me to require patients or clients to self-disclose while I remain silent about myself? Remember, we're co-creating change. Is the patient being resistant or non-compliant, or have I really just missed the mark? Notice how oftentimes when patients don't make progress, it's rare that we start with ourselves. We automatically assume it's something the patient or the client did wrong. They aren't committed. They're not ready for change. They must not take this seriously. I double dog dare every single one of you all to reframe these questions, not from what did they do wrong, but what can I do differently? Because that's how we co-create change from a culturally responsive perspective. Okay. There we go. So more questions. I've kind of been sharing all of it, but one quotation I like from the article listed below is, the real messy, complicated world is not controlled in the same way that the experiments where the interventions that were trained were developed. Instead, real world practice is documented and measured just as it occurs, warts and all. So does your intervention allow for warts? Because again, not everything gonna work the way you read about. And do we tailor, really ultimately, like, are we tailoring the interventions for the people we serve? Okay. And again, are we using only what feels most comfortable for us? Are we open to trying something new? There's a concept called practice-based evidence. And it is simply the idea that, like, one size doesn't fit all, and we have to be responsive to the needs of our patients and switch things up, modify it appropriately. That then becomes the evidence that the intervention by itself wasn't cool and you got to switch it up. But it's called practice-based evidence. So in my practice, I know that asking somebody who, asking someone just to sit there and mindfully become aware of their breath when their primary concern today is hunger, like, that's not evidence. So I know that from a practice-based evidence perspective, that's not a good intervention to use right then and there. It could be solution finding. It could be problem solving, even if I don't have the resource, or it could be the way we frame the intervention. I am quick to tell a patient, listen, I know deep breathing ain't gonna feed you tonight. I know that. But it doesn't mean that you have to suffer while we come up with solutions. So let's just for 2 seconds take a deep breath, recenter ourselves, calm down, calm our heart rate, allow our blood, our lungs to take all the oxygen it can take so that way we can think differently and better. about the problem, but I know that me teaching you this progressive muscle relaxation is not going to feed you tonight. And I want to reduce your distress right now. And I want you to have a tool that you can use whenever you need to slow things down so you can problem solve. But again, I'm not going to pretend that me teaching you how to breathe is going to feed you tonight or your kids. Okay. And then lastly, we want to make sure that we consider protective factors. One of the best ways, and this is sarcasm, to take care of patients and, you know, be on their team is to walk into a room and tell them to do exactly the things that they've already tried, but we just didn't ask about it. So remember that our patients are the most underutilized member of the entire team, the entire dyad, the entire therapeutic relationship. They are the most underutilized members of that team. We have to ask them about these protective factors, about their strengths, about their values, about their beliefs. And even if they are not something we're familiar with, we gotta be uncomfortable enough to make space for it if it will benefit the patient and if it doesn't cause you harm, because you're a human too and you don't have to be harmed to help somebody else. But we don't want to just pathologize everything. Like, it's totally okay. A transcript from me, I think you'll get the recording. And we might be able to put on closed captions, but I can't remember half of what I just said, Robin. But we want to make sure that we don't just pathologize things, that we focus on strengths as well. Okay? So with that being said, we now have 9 minutes remaining for discussion. I'm going to stop sharing and invite you all to reflect, use the chat box, come off mute, whatever, but let's talk a bit. I see no hands raised, so I've got a question for the chat box.
Dr.
Oh,
Winter, I was going to ask on your slide about like minority communities not trusting medical care. I see that often. I work in the cancer center, and I see a lot of families, especially minority families, having trouble accepting like chemo is like the only way to heal their child. How do you grapple with that? Because if they don't accept chemo and the doctor feels that is only able to be treated with chemo, then they contact us and to make a CPS report. So how do you I'm unsure how to navigate those situations when they arise.
So I have literally been in that position. Yeah, I've literally been in that position. I've worked in pediatric oncology, hematology, so the Peds Hemont clinic. And there was a kiddo with leukemia, which is a cancer of the blood. Y'all know that. And blood transfusions are often indicated, but there's at least one religious group for whom blood transfusion is not okay. Okay. And this family was practicing Jehovah's Witness. And you were not going to give their baby no blood transfusion. Like, that's just simply not going to happen. And I remember doing rounds and treatment teams and case teams with the oncologists, with the nurses, with all the people, with the social workers, everybody. They're like, we have to call, DCS, CPS, because this person is refusing to provide care for their patient, for their kiddos. And I was like, so what you're saying is that your belief system is more important than theirs. That's what you're telling me. And as much as it sucks, we have to provide all the information we have, give our strongest recommendation that we believe in this, if we do, and we honestly will have to honor what they decide, even if it feels yucky, because I refuse to call CPS on that family who was utilizing other faith-based strategies that were in line with their culture. Like, what made mine more important than theirs? That was like one of the hardest decisions I've ever made, because like literally we know that like if you give the kiddo the chemo, they'll likely be in remission and be just fine. But is my perspective more valid than theirs? And it's really hard because like I don't know. There's sometimes I literally don't know. Like, who am I to say that your faith is not going to be strong enough to cure your child? You know, I don't know. But as much as possible, I'm not calling CPS because you're making an informed decision to not choose that method of care. Like, they chose other methods of care. They just weren't going to do, you know, transfusions. They're like, we'll do anything but that. And so sometimes it's a matter of extending the range of treatment options that are available. We may just be palliative. It may not be curative, but like, here's some things we can do if you don't want that. Here's a version of this we can try. We really, really, really want you to try this one because we know it can be curative. However, I can't make that decision for anyone. Like, it's hard, and that may not help Destiny, but honestly, it's hard. It's so hard, and it's something you got to check yourself. Like, what makes my perspective more important or more valid than theirs? So I'll say that's clear as mud, the response that I gave you. You're doing good work, though. I know it's not easy.
Thank you.
And I've literally been in your shoes. I've worked in
it's
hemo.
tough every time.
Mm-hmm. All right, let's use one more opportunity for chat box before we wrap up. I want everybody who's still paying attention to me. I know some of you zoned out. My feelings aren't hurt, though. I want you to use the chat box to tell me one thing you're going to commit to doing differently as a result of this discussion today. And so, wait, before we do that, we're going to do a chat fall. Okay, so type it, but do not push enter. I'll tell you when to push enter, but I want you to type, but do not press enter, the one thing you're going to do differently after today's discussion, okay? So I'm going to give you like a couple seconds to type, but not push enter. And I'll give you like 30 seconds more to type, but not push enter. And yes, I'm going to say it over and over again because somebody's going to push the button when they're not supposed to push the button. And just 10 more seconds to type out the one thing you're going to do differently. Okay, when I say go, and only when I say go, I want you to push the button. Ready, set, enter. There we go. That's what I like to see. Good, good, good. Call out microaggressions, becoming aware and being comfortable speaking about cultural differences and privileges with families and patients. Remember humility. Yeah, try not to be weird. I appreciate that, Sarah. Advocate more for my families with cultural differences. Revisit my reaction response to microaggressions, not making it about me. I'm glad that resonated with you. And we do it without intent to harm. However, the impact is that it sometimes does. Yep. Ask more questions about cultural beliefs, values, practices. Be okay with being uncomfortable. Focus and be intentional regarding intersectionality. Yep, because we can never occupy space as a singular identity. It's just simply not possible. Challenge microaggressions in a strategic way. Strive to be more humble and observant. Check myself before we wreck ourselves, right? Discuss with my providers what we can do for families that have an alternate view of treatment. Yes, yes, yes. Cultural humility. Let me see. Being intentional and understanding from others. Cultural lens. Start the conversation with protective factors. I like that, Aisha. Like, whenever I'm working with kiddos, I like to say, tell me some things that make you proud about your child. How would you describe your child's best characteristics? And I love when the parents or the caregivers are like, they're such a caring kiddo. They love their siblings. They're such a good helper. And instead of saying, what are some challenges? What are some areas of growth? What are some things that, you know, are challenging you right now, but like, we can work on it. Not relying on others to teach me about their own culture. Yes, that's so important. And again, intent is that we are curious. The impact is that we've asked somebody else to do the labor and the work for us. So thank you all for this. There is 1 minute left, and I'm going to pass it back to Victoria and to Gina.
Thank you so much, Dr. Winford. That was a really great presentation, and I appreciate how you were able to make it work in a public space. And I appreciate all of you I mean, that chat call was great. It's really great to see that you were all taking in the information, and I think it's given all of us like something to reflect on. So thank you to all who are still with us. I will be sending out the follow-up email with the link to the recording of today's session, as well as the slides that Dr. Winford provided us with. But if you all don't have any question, that's wrapping it up then. We'll see you next month again. Thank you so much. Have a good rest of your day.